you for inviting me here to this lovely conference, to your beautiful country, to your beautiful city. It's a very impressive venue, and I'm very impressed by the choice of subjects which the organizers have very carefully thought out about. So I've been asked to speak about amblyopia and what we need to know. So I'll cover what amblyopia is, what are the effects of amblyopia on the eye, and how could we treat it. So amblyopia is basically a reduction in the vision in one or both eyes, which cannot be exclusively attributed to a structural abnormality of the eye. It could be unilateral or bilateral. So unilateral, I'll define if the difference between the two eyes is 2 or more lines. Whereas in bilateral, it depends upon the age of the child. As you know, the vision matures as the child grows older. So in a child older than 5 years, I would say vision less than 6, 7.5 could be considered as amblyopia. It's the most common cause of preventable visual disability in the children, most common cause for the monocular visual loss in kids now, and the prevalence of up to 2 to 5%. And it's caused by abnormal visual processing early in life. So for normal visual processing, you require a clear retinal image. There should be equal image clarity between the two eyes, and you need proper ocular alignment. So it goes on that visual deprivation or anisometropia or abnormal binocular interaction will lead to amblyopia. Vision is poor at birth, but it rapidly improves in the first 3 months, so that's called the critical period. And then there's a slow and gradual improvement till around 7 to 8 years of life, and that we refer to as a sensitive period. And the neural plasticity is known to reduce after about 7 years of age, but later interventions do improve vision in some extent. So amblyopia can be reversed if appropriate visual stimulation is provided in the sensitive period. So how do we treat it? Well, the basic strategy is you need to provide a clear retinal image to each eye, and you have to correct the ocular dominance. And this has to be done within the sensitive period, ideally, for maximum improvement, because the success reduces as the age increases, as I mentioned, due to the reduced neural plasticity. Now, there have been a lot of studies by the PEDIC group which have sort of guided us on evidence base of how to treat amblyopia. The first step is to correct the refractive error. So optical correction of refractive error is the first step. So glasses itself, they can, in around 3/4 of the cases improve vision 20/25, but that's binocular. But it is known that refractive correction alone can improve the vision by more than 2 lines in 77% of the patients. And actually in a third, it can lead to resolution of the amblyopia in cases of anisometropia. But even in strabismic amblyopia, it has been shown that the vision improves just by giving glasses on their own. So we in our practice tend to give a refractive adaptation period of around 4 months. So if anyone comes with amblyopia, just prescribe them with glasses for the first 4 months, and then you decide what further interventions are needed. So apart from glasses, the most common thing we do is, of course, patching. Yeah, this has been there for ages. Again, with the patching, there has been, should we patch full day? Should we patch a few hours, half an hour? So again, we are guided by the studies, and Holmes in 2003 showed that 6 hours of occlusion it can get equal improvement as opposed to full-time occlusion. So that is in severe amblyopia. In moderate amblyopia, it has been shown that actually occlusion for 2 hours, if you start, gives an improvement of equal magnitude to 6 hours. So it will be a good idea to start with 2 hours of occlusion, monitor the child. If it's not responding, then you increase it to 6 hours. For children with residual amblyopia after 2-hour patching, as I said, you can increase it to 6 hours, and that has been shown to have an additional improvement in vision. Patching should be considered even in older children. So although I said 7 to 8 is the age of sort of visual maturity, the plasticity is reduced, but there have been studies coming out lately of children up to 13, 17 years of age being offered patching, especially if they've not had treatment for amblyopia before. Of course, we must bear in mind that if you get them out of the suppression, there's always a risk of intractable diplopia. And also if you're patching them, you are disrupting the binocularity. So that has to be kept in mind. So glasses, we went to patching, and then the other thing is atropine penalization. So people working in the pediatric clinics must know that children are, very uncooperative. They will just strip the patch off, and if you have a kid with ADHD, autism, they're not going to keep the patch on. So the alternate is instill atropine. You instill atropine in the better eye, and you make the image sort of blurred so that the non-dominant eye then becomes the dominant eye. And again, pediatric trials have, compared the efficacy of patching and atropine as treatments for moderate amblyopia, and they have shown good results. Now, initially, although improvement was initially more rapid in the patching group, the between group difference in VA was small. So there was another trial from PEDIC which enrolled children from 3 to 12 years of age with severe amblyopia, and that also increased with improved vision with weekend atropine. So you don't have to use atropine every day. So in our practice, we usually use it alternate weeks. Although in the trials, they just use it for on the weekend. I'll just skip this because I'm just very short of time, and Jane will interrupt me. So in older children, amblyopia is improved with optical correction alone, but about one-fourth of the patients aged 7 to 17. For patients who are 7 to 12, 2 to 6 hours per day of patching along with near visual acuities and atropine has improved vision even if amblyopia has been treated previously. And for patients between 13 and 17, patching for 2 to 6 hours per day along with near vision acuities improved vision when amblyopia had not been treated previously. So coming on to compliance issue, as I said, compliance is a problem either with atropine or with patching when treating amblyopia. So what can you do to improve the compliance? I think the important things which have been proven by studies is educational programs or more effective communication with the children, with the parents is very important. Increasing the frequency of the physician checkup so the child gets familiar to you and actually directly speaking to the child and making him understand the need. Or even sometimes, the younger children, I say, you know what, if you're not going to patch, I have the 6th floor nurse upstairs. She has a big drill. She's going to drill a screw here, and we're going to screw your patch inside. So then you can laugh about it, but yeah, sometimes. So yeah, direct communication with the child, carrot or stick, but you speak to them. We can begin therapy with less intensive patching. So it's easy for you to say to mom that, oh, go and patch his eye for, little Johnny's eye for 6 hours, but she may not be able to manage more than 10, 20 minutes. So I think giving a sort of small segments of introducing to patching and then gradually building up. There are some newer treatments which have come up. So you have some special glasses. So what the intermittent occlusion glasses do is that every 30 seconds or so, one eye will go opaque and the other eye will then clear. So you're basically giving 50% occlusion. There's only been one randomized trial regarding this, but they have shown there is some effect from it. Then the new treatments which are coming is something called perceptual learning. So perceptual learning refers to something like, practice is perfect. If you keep repeating a task and if you keep practicing it, you will get good at it, okay? So perceptual learning involves doing certain interactive things with the amblyopic eye, doing some visual task in clinic, and this has been shown to improve the vision, but it doesn't necessarily relate to that task. So if you're doing a certain task about, let's say, contrast enhancement, it improves the other visual functions as well. And the basis for this is that there are persisting binocular neural circuits. So they're not absent. The neural circuits are there, they're just asleep. You just need to awaken them. So you stimulate the eye and the function improves not only for that particular function, but for other related functions as well. Dichoptic training refers to basically, you see, amblyopia is a binocular process. There is abnormal binocular interaction, and one eye is actively suppressing the other eye. So if you stimulate both the eyes, then that suppression is going to be lifted, and then the monocular vision will improve, and the other stereopsis will improve, and other functions will improve as well. So dichoptic training means that to the dominant eye, you produce image of a low contrast, whereas to the amblyopic eye, you produce, you give them images of high contrast. And this is in the form of video games, iPad games, which may be better tolerated by this generation rather than patching. So you would expect more compliance.
Just coming to the end now, Vinod.
Sure. So I'll just quickly say there are some pharmacological treatments as well. Things like levodopa has been given to increase the dopamine concentration in the brain, and because amblyopia is a neural process, and some other drugs have been used as well. I'll just skip this. So yeah, just go to the previous one if that's all right. So the new things which are coming up is pharmacological and epigenetic manipulations of these cellular and molecular breaks which have confined the plasticity to certain critical periods. So by new interventions, this critical period or the absence of neural plasticity can be reawakened again. So if you have older amblyopes and you give these treatments, you can cure their amblyopia as well. Thank you.
Thanks very much.
Sorry for.
Thank you very much, Vinod.